So guys, I'm going to talk about finding the pulse, because during CLI, critical limb ischemia, it's very common to find pulselessness, right? Because of 6 P's: pain, pallor, pulselessness, and perishing cold. So perishing poikilothermia. So it's going to be very cold. The affected limb will be very cold than the other limb in cases of CLI. And what else we have? We have paresthesia. That is, you'll find sensations like pins and needles because the nerves are active, and when they get ischemia, they feel pin and needle and paralysis. Sometimes you can have patient with chronic limb ischemia. That time you can have planned surgery. With acute and critical, you have emergency surgeries. Femoral artery, there was no pulse at all. Now after doing a fem bypass, you'll find good pulse. So there are different places in the body to find pulse. Carotid pulse, you can find it. You can find the brachial pulse, right? You can find femoral pulse. Now for a cardiovascular surgeon, or especially in vascular surgery, finding pulse is very important. Okay, so femoral pulse, it's very easy for you, right? Between right there in the midline of the inguinal ligament, you'll find it. So Mona, you can find it here, and it's a common thing. Like, she's doing it rightly. Many people do it with the tips. You should always use this part, all right? Next part. Now what happens is iliac, then femoral, superficial femoral, deep femoral. Yeah, it goes into different branches, and then you find the popliteal, which goes like this, almost like this. So what you'll do is you'll ask the patient to fold his leg a little bit, right? And then take 2 or 3 of these fingers, and a little lateral, you'll find in the rhomboid, in the diamond shape, you'll find the popliteal pulse, like this. So try like this. Then what happens? Then distal part, very important. Why? Because of course you're gonna find pulse a lot of time there. Femoral popliteal part. Here he was not having it, of course, because of stenosis, more than 20 centimeters. You can read about task classification. And then now in the distal parts, always is a problem, because it's the most distal to the heart, most distal to the body, right? And you can also find atherosclerotic changes. Yeah. There are different classifications. For critical limb ischemia, we use Rutherford's classification. So what happens after the popliteal artery? It goes like this: posterior tibial artery. Now for the posterior tibial artery, you'll find the Achilles tendon. This is Achilles tendon, and this is the medial malleolus. You see the bony bump? This is medial malleolus. Between the Achilles tendon and the medial malleolus, you'll try to draw an imaginary line, because the posterior tibial artery goes like this, right beneath the flexor retinaculum, right? So you'll place 2 fingers, and very beautifully you'll find the pulse. Wanna try it? Of course, it comes with a lot of practice experience, but this is the best location, okay? And then for the plantar arch, you'll see, okay, this part, you'll see the center over here, and you'll draw a line here, and again you will find the plantar arch. And anterior tibial goes, from here. So, okay, but we need, the most important is this one, for the posterior tibial artery and the plantar arch. Wanna try? And about the surgery, this is a fem bypass. Here is an incision of 8 centimeters here in the popliteal artery region. There are 3 segments of the popliteal artery: P1, P2, and P3. Just like in the carotid artery, we have 7 segments, right? Petrous part, cavernous part, cervical part, and those parts. So cervical part, you don't have the branches like that. It's very important. So P1 is from the Hunter's canal, from the adductor. When the adductor ends, Hunter canal ends, till the patella, you can say. Now the popliteal artery in the patellar region is P2, and patellar region to the trifurcation of the, till the tibial artery, peroneal artery, and posterior anterior originates. That is the popliteal's 3rd part, alright? So here in the P1 segment, we always, till the P1 segment, we should use synthetic shunts. You can use synthetic, but if you're going to P2, P3 or femtibial bypass, you should always use auto vein. Okay, because if you go later to the P3 part, there is always mostly development of thromb in the shunt. Now we're gonna see removal of the drainage. Drainage, we usually put it because to just remove the residual bleed inside, so there is no intramural hematoma or subdermal hematoma. So you see very, very beautifully, there's no hematoma, nothing. And these are Algover Donati sutures, far near sutures. The access, subsartorial access here, through the medialis here, we find out the popliteal artery. Mobilize both of them, stitch the distal branch one, then anastomosis, okay?